So, let's see. So any questions from any of the last stuff we covered? Talked about some geriatrics, had some urology. Nothing at all. All right, let's get into talking about emergency medicine stuff. Now, again, a lot of the meds we've covered previously obviously apply to emergency medicine. So, like, yeah, someone who presents with nausea and vomiting, what are you most likely going to give them? Some Zofran, right? So, again, I'm not going to belabor all those individual points again, how we use them for every single indication, and really try to here to try to introduce some new medications in the context of emergency medicine. But if you have any questions about anything you've covered elsewhere, feel free to bring them up. We can talk about them. This is something I really enjoy doing. I got to do my fellowship in toxicology and emergency medicine. I got to work in the PTR for many years, so this is kind of just what I like to do. I like emergency stuff. I like the variety, and it always keeps you on your toes, right? As you probably already noticed in your emergency medicine lectures, wide variety of different stuff, right? Anyway, so let's talk about rapid sequence intubation first. What is RSI? Sequential intubation done rapid. Yeah, okay, yes, absolutely. You could definitely say that is the case. But more specifically, we want to talk about the medications that are involved with this, because certainly the procedure itself sounds simple enough. You're just sticking an endotracheal tube down the patient's throat. Right? Easy enough, right? Not necessarily, right? There's a lot of complications that go into it. And so we have a lot of medications that we use to help out with this process, right? And so we kind of break it down into the preparation stage, sedation stage, and then finally the paralysis. And what's the point of paralyzing the patient when you're intubating? Yeah, so basically you want to get everything nice and loose so that way you can manipulate the patient. You're not going to have any kind of resistance. You're going to keep those vocal cords nice and open so that way you can pass into tracheal tube and get the patient intubated, right? Because when do we do RSI? Yeah, if you have like an impaired airway, if you need to make sure you need to secure that airway for that patient because either they're not supporting it themselves or something else going on that is preventing them from really oxygenating on their own. And so again, this is something that you can do under more controlled settings, like if you're taking someone back to, say, for like an elective surgery, something like that. But a lot of times in the ER, do we have the benefit of time or preparation? Not necessarily. And so this is why we do a lot of simulations with this kind of process, because we want to make sure that we can do it quickly, safely, and effectively, so that way we can get them intubated on the very first time, right? And so medications are really important to help out with that from a number of different circumstances. We'll talk about where these are playing a role. So anyway, so history is super, super key when you are handling these patients who might be coming in needing to be intubated. Now, again, are you always going to be the person who's doing the intubations? Not necessarily, right? But you never know. What if there's a mass casualty event and everyone else is busy with the patient? You're the one's got to do it, right? You're a small ER where you're the one provider that's left over. That's something you may have to consider. And it's good to know, what these patients are receiving. You may be the ICU person who's taking over care for them. You need to know what they received. There's a lot of different circumstances where you're going to be interfacing with these patients. And so this is why we cover it. But anyway, so history is super, super important because we need to cover things like allergies, right? So if they have something like an egg allergy, that's going to preclude them from getting certain medications. Anyone know off the top of their head what that might be? Yes, an influenza vaccine. Although we have recombinant forms, right? So that doesn't mean you can't get the flu vaccine if you have an egg allergy. However, if you're like, okay, this patient needs to be intubated, stat, is he updated today on his flu? Not a question we're often asking, however. Maybe in the history you can get a little bit later on. But we'll talk about things like Propofol, right? We talked about Propofol before as a sedative medication. Remember, it's in that lipid emulsion. Part of that is actually egg protein that's in there. So if you have someone with an egg allergy, it might be a bad idea to give them Propofol. It may not be a good agent to sedate them with. Ask about questions about neuromuscular disease, right? And so this is things like Duchenne's muscular dystrophy, things like that, where this can preclude them from getting one of the particular drugs we're going to talk about later on, because this can lead to some pretty potentially fatal outcomes, as we'll see. Oftentimes this is difficult because we don't really know, especially with young patients. It could be something that's undiagnosed for them, right? Especially depending on how early they're presenting. So we don't always know that information, but it's good to ask. Look at things like renal compromise. We'll talk about why that is in a little bit later on. Any kind of family history of malignant hyperthermia. Now, we talked about this previously. What causes malignant hyperthermia? Succinylcholine, which we'll talk about today, and what else? Inhaled anesthetic. Now, do we use a lot of inhaled anesthetics in the ER? Not typically. It's more in the surgical realm. We may use nitrous oxide every once in a while, but this isn't really the level of sedation we're looking for. Because when you intubate a patient, do you want them to be somewhat conscious, or do you want them to be out? I would like to be out for this procedure, right? Because it's not super comfortable having someone trying to jam a tube down your airway, right? So patients should be unconscious for this process. Anyway, history of asthma, any previous intubations or anesthesia, you want to ask about this. See if they've had any bad reactions to medications previously, because it may kind of guide you in deciding what you're going to be using in the future. Now, again, if a patient presents and they're unconscious and you have no family to get the history from, sometimes you just don't know, right? And we'll talk about which medications are safer to use in those situations than others. We'll talk about kind of the pros and cons amongst all of them. So what happens when we have a physiologic response to laryngoscopy, right? So that's where we're actually going to be inserting the endotracheal tube through the vocal cords. A lot of different things can happen here, right? So for instance, heart rate can be somewhat variable, especially you're going to tend to find that the heart tends to have a vagal response. And so you'd expect, in that case, heart rate to slow down, right? You vagal down, what does your heart rate do? It's going to slow down, right? So you're going to find some pretty predictable responses in heart rate, which can be problematic depending on what the patient's heart rate already is. You can find things like intracranial pressure may actually increase. Why might that be bad? Right? They had a stroke, may not want to do that. If any kind of like cerebral edema, maybe they had a head injury secondary to a car crash, anything like that. You're going to see increases in blood pressure and potentially increase in airway resistance. And this can sometimes present as bronchospasm, especially if you have like an asthmatic patient. Say they're presenting, what do you call it, like really severe asthma exacerbations. Status asthmaticus, right? Sounds like a Harry Potter spell. But basically, when they present like that, and sometimes they have to be intubated because they're not able to oxygenate on their own, or they're starting to tire out, right? Especially if you see those patients who are tripoding and you just know they've been working to breathe very, very hard for a long period of time, they're starting to tire out. That's sometimes we have to intubate those patients to breathe for them. And so that increase in bronchospasm, we can do something with that, right? We have medications that can help out with that. We'll talk about what those are a little bit later as well. Some of them we've already talked about before. So let's talk about the pre-medications that we're going to use. Now, again, I just kind of put the doses up here just for reference. You don't necessarily need to know the doses specifically for testing purposes here. But I want you to know what situations you'd want to know when to use these medications, because it can be very helpful in deciding, okay, well, because again, when you have the patient presenting, you may only have a few minutes to really think about, okay, well, what is the patient presenting with? What history do I know? What medications do I need to have available, right? Because again, frequently, at least from my standpoint, when I'm there in the ER and I'm seeing a patient coming in, a lot of what I'm doing is trying to predict what the future is going to hold and saying, well, what medications might we need? And so I need to decide, okay, well, do I think this patient might need lidocaine? If so, then I need to make that recommendation known. I need to say, hey, provider, would you like to use lidocaine for this patient because of X, Y, and Z? And they're like, oh, yeah, that's a really good idea, because can every single person really think of everything when you're in a really hectic, emergent kind of situation? Not necessarily, right? So it's good to have multiple minds kind of working together. Anyway, so lidocaine, we talked about lidocaine before. What do we use it for? As a local anesthetic, good. So if you need to sew up a laceration, you can help to numb up the area with lidocaine. What else can we use it for? Antiarrhythmics, right? You talked about using, anyone remember what class it falls into? The 1B, right? What is notable about the 1Bs? We're good on ischemic tissue, right? So it's good for potentially MI. We don't use it quite as frequently anymore as an antiarrhythmic, but that's one of the things we like to use it for. And so what's nice about this is it actually will help to prevent the gag reflex from occurring, right? So again, if you're trying to manipulate someone's airway, oftentimes people end up having a gag reflex. And so what happens, do you think, the intracranial pressure when you have that reflex? Tends to go up, right? So if I had someone who I was worried about increased intracranial pressure, I can try to numb up the back of the throat by using that lidocaine. This is something you're giving intravenously, but again, you get kind of a nice systemic effect from this. And this will help to blunt that response, helps to prevent that gag reflex, and hopefully will prevent any big spikes in intracranial pressure. Now, it's very easy to measure intracranial pressure. It's pretty invasive. You can get monitors to do it, but in the ER, you're probably not going to have that. So you have to go with the suspicion that the patient may have increased intracranial pressure, like if they have a head injury, or if they've had a potential stroke, or if they're coming in with a DKA that's very, very severe, it's been kind of long-staying for several days. These are all things you have to consider, right? Any suspicion of increased ICP, we go ahead and just administer it. Okay. Does anyone remember what kind of side effects I might see from this if I were to give too much? Seizures is one thing, right? So you can see that neurotoxicity can develop there. How do they manifest that neurotoxicity initially? Talk about tingling of the tongue or the lips or that metallic taste, right? But these patients are hopefully going to be sedated here pretty soon, so you may not be able to notice that. But think about patients with hepatic failure, renal failure. They're going to need less lidocaine overall, but this is usually just a single dose. We don't really have to consider that very much. If you use a drip for them, like say, for instance, for an antiarrhythmic, then you have to consider that, right? But that's the situation where we end up using lidocaine. Now, as I mentioned, why does it cause its anesthetic properties? Why does it numb that gag reflex? Right, remember it's a sodium channel blocker. That's how it works as an antiarrhythmic. That's how it works as a local anesthetic. The same thing is happening here. It's just working there on the back of the throat and blunts that cough and gag reflex from occurring. Up next, we have atropine. We haven't really talked too much about atropine, but if I tell you what it is, you're going to know a lot about what it does. So what is atropine? Anyone know? How's it work? Antimuscarinic, absolutely. So it's an antimuscarinic drug. So it blocks what neurotransmitter? Acetylcholine, fantastic. So it prevents acetylcholine from interacting with the muscarinic receptors. Now this is important because we're going to talk about things that affect the nicotinic receptors a lot later when we get down to our paralytics. But talking about atropine first, what sort of effects would you expect to see from atropine? Increased heart rate, right? So if you block acetylcholine effect on the muscarinic receptors on the heart, you should expect to see increases in heart rate, which is good because what do we say that laryngoscopy does? Cause increased vagal tone, right? So you can see that if you have someone who is maybe already bradycardia to begin with, or someone you're really thinking about maybe at risk for developing bradycardia, especially like very young children, we oftentimes will give atropine to try to bump that heart rate up in order to help blunt that, right? Now, patients already tachycardic, you don't necessarily need to give this, but it's something we want to consider there, right? And again, one of the big drugs we're going to use very frequently, which I'll oftentimes call Sux, but obviously that references what drug? Succinylcholine. We'll talk much more about that in a little bit. When you see Sux, that's basically what we're talking about, is just succinylcholine. And so that is one of the big drugs that will cause a lot of bradycardia. We'll talk about why that is, but that is something we'll use atropine for. Now again, what other effects might you expect to see from atropine? So antimuscarinic, what's my mnemonic for that? Dry as a bone, right? So how might that be useful if you're trying to intubate somebody? Secretions, absolutely, yeah. Secretions are a big thing. So you end up finding that if patients having a lot of secretions, it may be difficult to visualize when you're trying to intubate. It may be difficult to oxygenate if you have all these secretions that are down there. So atropine can be useful for that. It helps to dry things out, and that can help in the ventilation of the patient, right? What other things might you expect to see? So increased heart rate, decreased secretions. Blinds a bat, right? So again, sometimes you'll see atropine being used as eye drops sometimes if you need to cause what? Would it cause miosis or mydriasis? Mydriasis, right? And it prevents accommodation. So sometimes the atropine eye drops from that. Actually, I had an order the other day for atropine eye drops given sublingually. It was actually being used to help with secretions in a patient who's kind of unresponsive to other antimuscarinic drugs. There's kind of a unique kind of way to use the drug there, right? Yeah, so again, think about all those normal things that should happen. Again, what would it do to, say, temperature? May increase it, right? So if someone's already hyperthermic to begin with, this may worsen that a little bit, right? Something to consider. What about mental status? Altered mental status, confusion, potentially seizures in some rare cases there, usually with the overdose of things, antimuscarinics. But again, think about all these side effects that could occur in these patients here, right? Sometimes we have to intubate patients because they have an altered mental status such that they cannot protect their airway. And so again, if you have atropine on board, maybe that can be exacerbating that. It could actually be clouding the neuro exam you do afterwards, right? So these are little things to consider. Anyway, so those are the main pre-medications you're going to do with either deciding, do we need lidocaine, do we need atropine? And so I might present on a clinical vignette, say on the test, that says, hey, a patient presents, they had a head injury, now they are, you're worried about increased intracranial pressure and the heart rate's 45, what medications do you want to give as pre-medication? And you would say, lidocaine for the increased intracranial pressure, and what would I give for the heart rate? Give the atropine, right? So in that case, you'd actually end up using both pre-medications. Sometimes you don't need either of them. So again, these are kind of the more optional ones you're going to run into, and it's going to be much more on a case-by-case sort of basis here. Now, getting into the induction agents, when I say induction, what does that mean? We're knocking them out, right? So this is inducing a state of, it's not general anesthesia, right, because it's not going to be that prolonged, but basically we're just trying to induce unconsciousness in this patient. We want them to be sedated, so that way they're not fighting us at all, we can get them intubated, okay? And again, we're going to be using this along with our paralytic agents. Which ones do you think we want to go first? Probably the sedatives, right? Would you like to be paralyzed without being sedated? No, that is a nightmare that no person should have to experience. Imagine being, you ever have that waking feeling where like you're kind of locked in, like your body's not moving, even though your brain's kind of awake. You never experienced that. It's pretty scary. It's only happened like once or twice to me. It's that weird time in Tijuana. But anyway, so again, you always want to make sure you're giving sedatives prior to paralytics. You don't want to give it the reverse way because that's not going to be good for your patient, especially if they remember any of this stuff. So induction agents, again, these are meant to try to sedate the patient. Most frequently, what you're probably going to end up using is a drug called etomidate. We talked about this briefly before back in the surgery section. A lot of these we've already covered, but I'm talking about how it will be used more in the context of emergency medicine. Etomidate is good from our standpoint because, one, it has good rapid onset and offset. Now, why do you think we want something with a rapid on in terms of intubation? You want to do it quickly, right? We want something that's going to have a fast onset, so we knock them out, give them the paralytic, get them intubated, and then we're done. Okay? Why would we want rapid offset? Well, we want to be able to potentially do something like a neuro exam, right? So again, you want them to not be under the effects of the medication for a very long period of time, because if you need them to, especially if they had something like a stroke and you're trying to do a good neuro exam, it's going to be difficult if they are sedated from the medications there. In some cases, you don't necessarily all that too concerned about it, because when that patient wakes up, what are they likely to start doing? You wake up and you have this tube down your throat. You're going to be very cooperative. Not often, right? They're going to probably start to try to fight you. So this is why it's important to make sure we have continuous sedation that's on board. If you remember from your prescription assignment, what did you have to write for that intubated patient? Fentanyl and Versed, most likely, right? So that's probably the two more common ones you're going to run into. We had to sedate the patient, make sure they are being synchronous to the ventilator, not fighting it. So again, these are going to be quick-acting agents. If you need them to come out of it very quickly, these are good agents for that, so that you can do your exam. And then oftentimes you're going to probably end up leaving them sedated, because that way they can stay on the ventilator with really no fighting it. But anyway, so etomidate's a good one we like to use here. The big thing to focus on with the induction agents is what are the cardiovascular effects you're expected to see from them, right? So if I have a patient coming in with sepsis and they're in hemodynamic shock, they're very vasodilatory, they're leaky, have leaky capillaries, and they're hypotensive, do I want to give them a drug that's going to make them more hypotensive? Probably not, right? I may want something that's either going to be neutral or try to raise that blood pressure back up. And so that's why it's important to consider what the patient's situation is and what sedative you're going to want to use for them. Okay, so etomidate's a good one because of very minimal hemodynamic effects. And you're going to find that the respiratory effects are going to be relatively minimal as compared to the other agents. And so when I say the respiratory effects, I'm really talking about how much of it's going to cause your airway to, or your respiratory drive to take a hit, right? So again, if you think about something like fentanyl, that would have a very negative effect on your respiratory drive. This is going to be a little bit more minimal than that. However, we're intubating the patient, we're going to be breathing for them, so hopefully we're going to be taking care of that from that standpoint. Anyway, again, this kind of fits into a class on its own. It's not really related to any of the other agents here, but again, it's working on those GABA receptors, right? It's helping to open them up to allow for more chloride to flow in. What does that do? So chloride flows into those neurons in the brain, become hyperpolarized, action potentials are less likely to occur, and you get sedated, right? Just like your benzos are kind of working, just like your barbiturates are working, just like propofol. These are all helping GABA to start to work better, so that way it's going to have hyperpolarized neurons. You're not going to fire off so much, and that's what causes that sedation. Okay. So again, helping to enhance GABA's effects here. This is mainly on the GABA A receptor. Remember, where did we talk about GABA B? It's a lot to do with our skeletal muscle relaxants, right? So if you think about things like baclofen, Sanidine, etc., we talked about those briefly back in the pain management section. We use those a lot to help as a skeletal muscle relaxant. We use those a lot, especially over at Nemours, in patients who were actually had 2 cases of this yesterday. We had scoliosis surgery. And so if you imagine, if you're trying to straighten out someone's spine, you don't want them to wake up and then having that pain associated with that. Because again, when you have pain, what does your body tend to do? You tend to spasm, right? So again, you're trying to prevent that, so we'll give skeletal muscle relaxants like methylcarbamol, things like that, to try to help loosen that up. But those are mainly working with GABA B. Things like your barbiturates, your benzodiazepines, etc., are on GABA A. So that's the main thing we're focused on here, right? And again, depending on the dose you're administering, can provide anywhere from light sleep to a very deep coma. We want to go probably somewhere in between here, where the patient's going to be unconscious. We can get them intubated and be done with it, right? And again, very dose-dependent effects here. So typically, most adult patients end up getting like something like 40 milligrams, knock them out. Then you can do what you need to do. And again, you're going to find that the duration of sedation is going to differ between the different agents here. And so with this one, you probably have like 20, 30 minutes or so where that patient is going to start to wake up again. And that's one of the big things I want you to consider if you're ever dealing with intubations, is that to consider what happens when things don't go as planned. When do you need to start consider redosing these medications here, right? So again, if things are going, it's already been 15, 20 minutes. You sort of see the patient start to wiggle around a little bit, then you know they're probably coming out of it. You may need to redose them with further medications. It's one thing you want to keep in the back of your mind there. So, as mentioned, this is good for induction agents prior to neuromuscular blockade. When I say neuromuscular blockade, what does that mean? It means giving a paralytic, right? So again, we'll talk more about those in a little bit, but basically that means we're causing paralysis and you need to get the sedative beforehand. The only contraindications are really if they have an allergy, and most patients I've never seen would have an allergy to etomidate, so no big contraindications from that standpoint. This will not be the case for every medication we'll talk about, but this is a nice safe one to give for the majority of patients. Again, rapid onset, so you have a rapid loss of consciousness. And you're going to find, even within one arm to brain circulation time, because frequently, where are we administering these medications in terms of IV access? Probably in a peripheral line, right? If the patient's presenting in the emergency room, they probably don't have a central line. Most patients don't come equipped with that, unfortunately, right? That make things easier, but they don't. But usually it's a peripheral line, so even by the time it goes from the arm to the brain, it's going to knock them out. So it's a very rapid acting from that standpoint, which is what we like. And then because it has rapid clearance from the CNS, the patient will come out of it. So it's rapid offset as well, which is good if you need to do something like a good thorough neuro exam once they're intubated. So one thing to note here as well is that not a lot of metabolism effects you need to worry about, though. You'll see that a lot of it ends up getting excreted through the urine, but the elimination half-life is something to note here. So again, fairly short acting, which means that within 15, 20 minutes or so, the patient should start to come back out of it, right? It's not going to be like an immediate flipping a switch where they're immediately awake, but it's going to be more of a gradual process. So if you start to see the patient start to kind of move around, start to wiggle a little bit, that's when you need to be cognizant of maybe we need to give another dose here, right? And so obviously if you're going to be increasing, you're going to have increased effects, synergy if you're combining this in any other medications here, right? So again, if they had come in and they need to be intubated because they were overdosed on opioids, you're going to have synergistic effects of those, right? If they had benzodiazepines they've already received, these are always going to have synergistic effects, so just be aware of that. Other than that, no really big interactions to speak of with etomidate, which is good. Now, one thing I do want you to know are some of the side effects that can occur with this. And so sometimes you can actually see some abnormal muscular movement, so things like trismus. I don't know what that is. Lockjaw, essentially, right? Do you want to have a patient with lockjaw when you're trying to intubate them? No, you want things nice and loose in here, so that way you can try to get them, you want them to be very compliant, so that way you can get the endotracheal tube in, right? So you have to get the laryngoscope and then an ET tube in. Do you know how we would treat that if they have lockjaw? Well, we can paralyze the muscle, right? So we're going to give a paralytic anyway. So frequently this doesn't come up as a big issue here. And then you can also see some myoclonic jerks, some facial twitching, things like that. Again, it's pretty variable. This will be important, though, because there's another medication we're going to give oftentimes after etomidate that also causes a lot of twitching. So sometimes it's hard to tell whether it's the etomidate or it's the other medication. We'll talk about what that is in a second. Anyone know what that drug is? Good, I'll teach you something new today, for once, right? Anyway, this is a really important point. So imagine you're the ICU provider, right? You're going to be admitting this patient overnight who received, say, etomidate and succinylcholine, secondary to losing their airway because they're septic and they're altered, and so you end up admitting the ICU. One thing to note here as well is that etomidate can cause a transient decrease in cortisol concentrations. Now, why do you think that might be a problem? Not an issue. What does cortisol do for us? You guys are replete with cortisol right now. You should know what cortisol does to you. You get so much of it, right? Helps with blood sugar, absolutely. What else? Helps with blood pressure in terms of volume, right? Absolutely. So this is one of the big things you have to consider here. So you have this transient decrease in cortisol. The glucose issues are not quite as frequently of a problem, but the blood pressure issues can be. And so what you find, especially with someone who is having a large inflammatory sort of process, so say for instance someone is in septic shock, right? So they have an infection, maybe a bloodstream infection that's causing their capillaries to be very dilated and very leaky, right? So those gap junctions are going to be more opened up, and that allows fluid to go where? Out into the interstitial space, right? So again, the effective blood volume is low, okay? One of the things that can help with that is actually with cortisol. So you can actually use cortisol to help for the mineralocorticoid effects, right? And our main mineralocorticoid is what? Aldosterone, right? But cortisol has some activity there as well, and so you find that if you lose those cortisol levels, this can actually worsen the hypotension. And so frequently you're going to find patients who may have gotten adequate fluid resuscitation, they've gotten liters of fluid, still hypotensive. So you start them on pressors, which we'll talk about a little bit later. They're still hypotensive. Oftentimes what we need to give them is what we call stress dose steroids, or we'll give them some doses of hydrocortisone. Hydrocortisone, what's another name for that? cortisol. That's what we produce, right? We produce hydrocortisone essentially. And so that is going to help out with the blood pressure. All of a sudden you'll give them that and all of a sudden their blood pressure will rise back up. You can get off some of the pressors and oh wow, that totally fixed it. In some cases it can be exacerbated by things like etomidate. Now again, it's going to be more of a transient thing, maybe only lasting maybe 24 hours or so, but it's good to note that, hey, this patient got etomidate. If I'm having trouble getting their blood pressure under control, perhaps I need to give them some exogenous glucocorticoids in order to help get that back under control, right? So just something to think about. The etomidate is a notable, unique sort of side effect you see with that, okay? Okay, other drugs that we could potentially use for induction includes our benzodiazepines, right? How do benzos work? They bind to the what receptor? They bind to the benzodiazepine receptor on the GABA A channel, right? And again, they're helping that facilitation of better binding of GABA to the channel, right? You know, opens up, allows chloride to flow in, hyperpolarizes. Again, you get the similar sedation as what you would see with etomidate. However, you're going to find that these are used less frequently. However, there are some clinical situations where the benzos are going to be potentially preferred. Now, remember, what do benzos do for us? They provide sedation. They provide anti-amnesia. Good. I'm glad you guys knew that because I forgot. And also it's nice because they have these anticonvulsant properties, right? So again, these are first-line treatments for seizures, right? Patients presenting and they're in status epilepticus. You have to intubate because they're not protecting their airway due to that. Chances are they've probably gotten several doses of benzos to begin with, all right? And so this can be very useful from that standpoint. Now we like midazolam. It's a little bit more fat soluble than Versed and so than Ativan. And so you're going to find that it has a little bit faster onset, which is good in cases of rapid sequence intubation. We're able to get into the CNS a little bit faster. It's going to be able to leave a little faster too, so it has a relatively fast offset as compared to something like Lorazepam or Ativan. However, Ativan we said we liked better for seizures because it has a little bit harder time getting to the CNS, but once it's there, it sticks around for longer, and we see less recurrence of seizures in a lot of cases. However, if you say, hey, you know, if I told you we're on shortage, we don't have any midazolam, you say, well, can I use Ativan? Absolutely, right. So again, they're relatively interchangeable from that sort of standpoint. Okay. Again, just to give you an example of what the dosing is going to be looking like here. Again, the onset's pretty rapid, so again, within 1 to 2 minutes or so, the patient should be well sedated, and you're going to see that the single dose duration around 15 to 20 minutes or so. So decent. Actually, and what I find with a lot of cases that Versed tends to last a little bit longer than that, than what they actually say. So you may have a patient who may not be completely back to their baseline for at least an hour or two, and so due to that, I find a lot of patients or a lot of providers don't necessarily like to use Versed for intubation, but it is an option. So if a patient's seizing, it could be a really good option for them, right? Again, looking at this, you're going to find that patients who have a longer half-life tend to be those that are maybe geriatric patients, right? So maybe they have kind of end-organ decrease in function. As CHF, if they're obese, they tend to have a little bit longer duration of action from this. And again, that delays your time to getting back to baseline so that way you can do your neuro exam. However, if you were looking at doing your prescription assignment and you were sedating them with a benzo, what do they most often recommend? What did you see? Versed probably gets used far and away the most commonly for long-term sedation for patients who need to be intubated, right? So again, most of the time your patients may not be inducted with this, right? They may not undergo induction with midazolam, but they may be put on a drip afterwards in order to keep them sedated, to keep them synchronous to the ventilator. Okay, so just something to note there. Next up, we have one of my favorites. I love me some ketamine, Special K. Going to the K-hole, right? Actually, K-hole's not a good place. It's another name for that dysphoric reaction you can end up running into. But remember, ketamine is nice because it's a dissociative anesthetic, right? It kind of causes that mind out of body sort of experience. You can see, especially if you're using lower doses for things like procedural sedation. And how does that work? How does it have its mechanism? How does it cause the dissociative anesthesia? It blocks the NMDA receptor, right? So it's blocking glutamate. So this is novel in the fact that it does not work through GABA receptors, but it works to blunt the effects of glutamate, right? So remember, GABA tends to be inhibitory, so I can enhance that. It's going to sedate the patient. Or glutamate tends to be excitatory. If I can blunt that, that's going to help to sedate the patient as well. So, and again, you get a different flavor of it. This is why I get that dissociative sort of effect from this, right? Again, derived from PCP. Anyone know the other name for that? Probably saw on Dr. Austin's test. Angel dust, right? What's the actual chemical name for it? Phencyclidine, right? So that's why you see a PCP. So phencyclidine is the chemical name for that drug there. And Again, angel dust is the kind of the common term for it. You don't really see much PCP around nowadays, mostly amphetamines you end up seeing, but it is a derivative of that. And so again, when you think about, like, you hear cases like PCP intoxication, what do they describe the patient as? Very aggressive. What else? What about their strength?
Very strong.
Super strong, inhuman strength. What do you think that is? Because they're dissociated. They're not. They may be experiencing pain, but they don't. It's not being communicated up to the brain there, right? So again, they can act. They can do things that we would normally stop doing because it's hurting us. Ow, stop. Brain tells you to stop. They don't get that signal there, right? That's why they end up being kind of considered to be super strong. Is mainly because they lose that sort of response to that pain there. But anyway, that's why we like ketamine for. That's why we like to use it for things like reducing fractures and other procedures, because it helps with that dissociative effect. They don't experience that pain there. Even though their body may respond to it, may hear some moaning and things like that, they're not really there so much. So I like to tell kids before they go under, what do you like to do? Oh, I like to play baseball. All right, think about playing baseball with your favorite baseball player. Have a great time. They come back out and they're like, oh, it was great. I was playing with Babe Ruth, and it was awesome. Literally the only baseball player I can think of. But he was great. He's hitting home runs all day long. But by doing that, it's good because they get the dissociative sort of effect there. Anyway, other nice things about ketamine, which is good, is one, it's rapid acting, rapid offset, which is again good from an examination sort of standpoint. But other things that are good for it as well is it causes catecholamine release. It's going to be kind of a double-edged sword here, right? So by causing catecholamine release, what sort of cardiovascular effects would you expect to see? Catecholamines include what? Norepi, epinephrine, right? So again, what would that do to your cardiovascular system? Increase your blood pressure, increase your heart rate. Put it right there on the slide, guys. Come on, everyone with me. Yeah, so again, if you had a patient who's coming in, they're bradycardic hypotensive, guess what? This is a pretty good drug for them because it can help to increase catecholamine release. You're going to increase their heart rate and blood pressure and kind of get that back under control. So in fact, in some cases, it may be good from, say, a sepsis standpoint, right? If you want to administer this, help get that blood pressure back up. However, a patient already comes in and they're very hypertensive to begin with, this may be bad for them, right? So they come in, their blood pressure is 180 over 120, not a good drug for them because you know you're going to see a pretty predictable rise in blood pressure. And very frequently, if you were to see someone who was abusing something like PCP, what does their heart rate and blood pressure usually look like? Usually pretty sky high, right? Because again, it has that sympathomimetic sort of effect, right? When say sympathomimetic means it's mimicking the sympathetic nervous system, right? Other nice things about ketamine includes the fact that it's a bronchodilator. So who might that be good for? They're having any kind of reactive airway disease or reactive airway to the laryngospasm or laryngoscopy, or, as you said, asthma. So like status asthmaticus is a good drug in order to either induct the patient with or to sedate them while they're on the ventilator. So I see this used somewhat commonly for that patient subset. The other nice thing, though, is it leaves the respiratory drive intact. So why is that important? Well, if I can't get that airway initially, then you still want the patient to be able to somewhat breathe on their own. That's going to be more beneficial than they have no airway or they have no respiratory drive whatsoever, because then we're still having to use the bag valve mask and all that in order to make sure they're still taking oxygen. So again, this is good. And in fact, I see this used a lot for patients who need to be intubated who are still conscious. So you can do like a conscious intubation in some cases. And the example I'll cite here is I haven't seen it too commonly, but this is a good example of it. So if you have a patient with angioedema, what kind of drug class do you think about as commonly causing that? Lisinopril, ACE inhibitors, right? A lot of you do that bradycardia, but I remember having a patient who came in. He had a known reaction to angioedema to lisinopril, but was really worried about his blood pressure, so he decided to take it anyway. And guess what happens? Comes with angioedema again, right? So he comes in, his tongue is absolutely massive, just sticking out of his face. He can't even keep it in there. It's so large. You know, his whole face is swollen up. And so what is a concern at that point? Airway. You're going to lose his airway, right? Because it's going to get so swollen, he's not going to be able to oxygenate. So we've got to do something for him. So we decided to go use a fiber optic scope and do a nasal intubation. So actually we're going to go in through the nostrils. Now, again, this is the patient who we were worried about the airway closing off. We wanted to keep his respiratory drive intact. I mean, he was still conscious. He was still with it. So we ended up using ketamine. That way his respiratory drive's intact. He's able to still breathe on his own. And we were able to get that scope down. And then basically had the fiber optic scope go down, get past the vocal cords, and then kind of get a nasal tube down, kind of snake it over that. And then that way we're able to get the patient intubated. After that point, we could sedate him all we wanted because we had the airway secured at that point, right? So that was a good situation for there. Very interesting situation hearing a guy who he was having a whole conversation with Jesus at the time, talking about his blood pressure when he got the ketamine. Very strange, but Again, we got the airway. That's all we need to do, right? Other things you can see with ketamine, it's a sialagogue. What does that mean? It's a fancy way of saying causes secretions, right? So this is something where you may need to use something like atropine, especially if you're getting repeated doses of ketamine. You may need to consider giving atropine to help dry out the secretions. That could be a good pre-med if you know you're going to be giving ketamine. Don't always have to do it, but it's something to consider, especially if the patient already has an history of having a lot of secretions anyway. Could be something to consider. Now, a lot of people will say, well, if you have worries of increased intracranial pressure, don't use ketamine. There's not really any evidence to say that that's true or not. However, a lot of people will probably avoid it just in case that it could cause any increases in ICP. Right? So again, in those cases, there probably would avoid it, although there's no definitive evidence saying you have to. Right? It's probably still a safe drug. We also mentioned the dysphoric reactions. Right? So what are those? And we could have a very bad trip, right? And so they get very anxious, they can get potentially aggressive. However, think about this, you're intubating the patient with ketamine, you're probably going to put them on sedation afterwards anyway, so they're going to be sedated through that regardless, right? Normally, if this patient has a dysphoric reaction, say we reduced a fracture or something, and they're coming out of it and have a dysphoric reaction, what do you give them to calm them down? Give them benzos, right? Well, if you're sedating with midazolam and fentanyl, they're already getting that benzo anyway. So it's less of a concern if you're going to keep them on sedation, but if not, if it's going to be just a short course kind of procedural sedation, that's when you consider that. Now, again, who are you more likely to see that in? Probably adults. Now, does it mean you can't give adults ketamine? No, it's just a warning, right? It's not an absolute contraindication by any means, okay? Vomiting is also pretty another common one you're going to see with this. Now, again, why that might be a concern for someone getting intubated? You worry about aspiration, right? However, once we get that airway secure, once that cuff is nice and inflated, you're not really worried about aspiration at that point so much, and so it's less of a concern there. But if you know you're giving ketamine, you may want to give some Zofran anyway. And again, by the patient undergoing laryngoscopy, regardless, what do we say about that cough and gag reflex? It's probably going to get activated. They may also vomit just from that in and of itself, so Zofran might not be a bad option. Okay. Up next, we have Propofol. You remember what this turns your urine color? Green, yes, absolutely. So again, Michael Jackson may have died with green urine. We don't know. No idea. But that is a common thing you might see with that. Because again, if I saw green urine, especially on the ICU, you're doing your rounds, you see some of the Foley in a catheter bag is holding a bunch of green urine, you would suspect what? Infection, right? However, it's probably due to the propofol, right? So again, if you can link it back, you can sometimes rule out the scary stuff. It's just a normal side effect. And again, what is notable about this is the fact it's in a lipid emulsion, right? So we have to put it into a lipid base, a fatty base, in order to get it into solution, okay? Now, this is another common one. You'll end up seeing patients being on for sedation, like long-term sedation when they're ventilated. So if you're not using fentanyl Versed, another common one is propofol by itself, okay? Can be used there. Now, again, we said as far as allergies go, who do you have to worry about? Egg and soy allergy, right? Because again, you have egg and soy proteins as part of that lipid emulsion, so you want to make sure you screen for that if you can. If not, if you have a patient who you gave it to and they had an anaphylactic reaction, what would you give them anyway? What do you give to anyone who's getting an anaphylactic reaction? Epinephrine. What else? Benadryl. Steroids, right? We'll cover this again, but again, don't forget about that stuff because this is important for emergency medicine. You never know when a patient has a rogue peanut come and enter their life and cause an anaphylactic reaction, right? Peanuts are everywhere, if you didn't know. But one thing to note with that is just screen for those allergies if possible. Again, avoid them if they have a history of an egg allergy. Again, don't give them the flu vaccine as well. But again, if you're intubating, not a big concern, right? Anyway, another big thing to know is this can cause hypotension. So if you have a patient who's already hypotensive to begin with, is this going to be a good drug for them? Probably not, right? So again, I've had cases where I've been rounding on an ICU rotation and rounding, and you see a patient who's got septic shock and they're on 3 or 4 pressors and they have them intubated and they're on propofol for sedation, and say, well, have you tried using something else? I mean, fentanyl and Versed instead? And say, oh, no, I didn't think about that. They switch it over, and guess what? You get them off like 2 of those pressors. So the hypotension is going to be dose dependent, depending on how much you have to give in order to keep them sedated, but it's something that you have to be careful of. So if you see the blood pressure dropping, again, you don't know if it's the disease state evolving or it could be related to the drug. Try to eliminate the drug if you can to see if that's what's causing the issues there. Okay. So any questions so far? Those are the common sedative agents you're going to be using for intubation purposes, right? So again, by far and away, the most common one you're going to end up seeing is probably going to be etomidate. And then under special circumstances, you might use some of these other ones, right? So the patient's hypertensive was a good agent to use. Propofol will be okay, right? Etomidate's probably okay too, just because, again, it's going to have neutral effects on the hemodynamics. But if you want to get the pressure down, propofol is not a bad option, right? If the patient's hypotensive, what's a good agent? Ketamine's a good one. If they have status asthmaticus, ketamine's a good one. Right, so you can kind of think situationally what's going to be better. If the patient comes with status epilepticus, what might be okay? The benzo's fine. Propofol actually has some anti-convulsant properties as well. So sometimes with patients who are failing benzos, we actually use propofol as a good option as well. So kind of think situationally what drug is going to be best for your patient, right? Okay. No questions. Let's do a 10-minute break. We'll come back and continue on talking about our paralytics. So moving into our talk of paralytics. Is there any questions from the first half by any chance? You guys all seem like you've received some paralytics for a chance. Just kidding. Anyway. All right, so another term for these medications will be neuromuscular blockers. Now, in terms of high-risk medications you might be administering, what are some examples of high-risk medications? No. It's a high risk. Some dangerous drugs we've used so far. Well, insulin's going to be a high-risk medication, right? Cause someone to go hypoglycemic. Pass out, you just think having a nap. No, they're actually dead. Right? It's not good. Not great. But neuromuscular blockers are another one of those things on there. You do not want to accidentally give a neuromuscular blocker to someone who is not prepared to have their airway taken over. Okay? Because if you give someone one of these, what happens? Do you think? All the skeletal muscles are going to get paralyzed, and that includes which important respiratory muscles? The diaphragm and your intercostals, right? They're just not going to be working at all, and so they're going to stop breathing on you pretty rapidly. So you'll find if you look at where these are stored, like in the hospital, like you'll find there's oftentimes like multiple warning signs, and they're in locked bins and all kinds of stuff because you don't want to accidentally give one of these inadvertently to someone who is not ready for it, right? But anyway, what this is going to do is basically by blocking the natural signals they get, and again, we're going to go back and talk about the neuromuscular physiology here a little bit, but the transmission of the nerve impulses to the skeletal muscles. So even though your brain may be telling the body, hey, move your left arm, nothing's going to happen, right? You guys watch Kill Bill ever? She's like, move your little toe, right, or whatever it was. You can't do that, right, because you're basically blocking all those nerve signals from getting to the actual muscle itself. We'll talk about the ways we're going to be doing that. Now, notice here it doesn't really have any direct effect on the CNS. You're not going to find it has no effects on the heart, the digestive system, really no big responses there, right? So again, anything that's handled autonomically speaking is going to be fine. It's really just a skeletal muscle transmission. Anything under kind of voluntary control is going to be taking a hit there, right? Also here as well, will have no level or have no effects on the level of consciousness or cause any differences in pain perception, which is important, right? Because what did I say to give before you give a paralytic? You give a sedative, right? Because again, you do not want these patients to be conscious of what you're going to be doing to them or for them during that process, right? Also has no effect on seizure activity. Now, however, how could you tell if someone's having a seizure? They're convulsing, right? So again, very obvious to tell if someone's having a grand mal seizure because they're going to be on the floor convulsing, right? Well, if I were to give that person a paralytic, what would happen? They'd stop moving, right? Now, does that mean the brain has stopped firing off all those signals? No, it's still going. So you can have someone in what we call non-convulsive status epilepticus, where basically, even though the body is not really having any outward convulsions, you can find the brain is definitely still seizing there. And so that's, again, another big reason why we like to use short-acting paralytics for these patients, because especially if it was someone coming with status epilepticus, and I wanted to see if they're still seizing, I want that paralytic to come off, so that way if they're going to convulse, they're going to convulse, and I can see that, right? That's important to know. So again, really just affecting the skeletal muscle, nothing else. Yes, sir? Absolutely, yeah, and so sometimes that's what we'll do. A good example of this would be a patient, if you remember for COPD, what drug did I say was like really kind of dangerous to use? We don't use it too much anymore. Theophylline, right? So a lot of patients, you'll find very old patients who are being managed by even older providers who still use theophylline occasionally. And so I had one case where a very old lady came in, probably in her 80s, and she had not had her theophylline dose probably adjusted in probably 20 years. She gets dehydrated. Theophylline's really eliminated. So what happens to the levels of theophylline? Elevate pretty precipitously, right? And so we end up finding she comes in for status epilepticus, right? She had a lot of theophylline on the brain. If you remember, theophylline blocks the effect of what chemical? Sometimes we use this chemical for SVT. Adenosine, right? It's actually an adenosine antagonist. Remember, for SVT, what does adenosine do to the heart? Stops it for a second and then has a very short half-life, so then heart starts back up, right? Hopefully normal sinus rhythm. Well, same thing happens with adenosine in the brain. It helps to kind of slow things down, right? It's kind of like similar to GABA, has kind of a brake on the system. Well, if you have an adenosine antagonist, it's going to cause all that brake to go away. And guess what happens to the brain? Starts to seize, right? Because you have all these signals getting sent inappropriately. So this patient had too much theophylline in the brain, was blocking all that adenosine, was coming with status epilepticus, right? And how do you define status epilepticus? Prolonged seizure. Really, it's multiple seizures where they don't return back to baseline, right? So again, they stay in that post-ictal state, and then they go back into another seizure. That's kind of the definition there. And so we found this patient, she's in status epilepticus, and so we needed to intubate her because she was not protecting her airway any further. And so we went ahead and gave her, etomidate and probably rocuronium, which is a drug we'll talk about in a second here. And so the patient stopped seizing. And you're like, oh, wow, the patient stopped convulsing. Everything must be good. However, found that the neuroexam was still not responding at all. We decided to get a bedside EEG, and we could determine that the patient was still in full-on status epilepticus, but it was a non-convulsive form because basically the paralytic was still on board, and even afterwards she was still having a non-convulsive, and the brain just kept going. Unfortunately, we couldn't do anything for that patient. She ended up passing away from that. But again, just another thing to note that bedside EEG in that case was very useful for helping us to determine is the patient still seizing or not. So, I add animations here, but regardless. So we have a couple of different varieties here. We're going to have what we call our depolarizing, and we're going to have our non-depolarizing neuromuscular blockers here. Okay. So what do you think is the difference between these two? One's going to depolarize the muscle, and one is not going to depolarize the muscle, right? Very simple as that. So the one depolarizing neuromuscular blocker we have is called succinylcholine. You hear people talk about sucks. That's what we're referencing there. You'll see that it causes certain physiologic effects due to the fact that it's a depolarizing neuromuscular blocker, as opposed to our non-depolarizing neuromuscular blockers. And that's going to include things like pancuronium, rocuronium, vecuronium, and again, they're going to be classified by specifically what they're going to do on that motor end plate. And I'll show you some diagrams in a second here to kind of illustrate what we're talking about when we're talking about depolarizing versus non-depolarizing. So imagine here we have our motor neuron, right? So imagine this is residing within the CNS, and this is going to be traveling down all the way to the muscle. And at that point, what does this release onto the skeletal muscle to initiate movement? Acetylcholine, right? So acetylcholine gets released. What type of receptors does it interact with? So it's muscarinic has to do with the parasympathetic nervous system. Nicotinic, absolutely. So it's nicotinic receptors here that we're talking about. So again, when you activate the nicotinic receptors, that's when you start to have the action potential being generated because you open up sodium channels and blah, 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 calcium release, all that other stuff happens, right? But we're mainly focused on the interaction between acetylcholine and the nicotinic receptors here and how they're actually causing this movement, okay? So again, imagine this is a skeletal muscle fiber or a skeletal muscle neuron innervating there at the motor end plate. You find this is releasing acetylcholine onto the nicotinic receptor. Now again, acetylcholine is normally broken down by what enzyme? Acetylcholine esterase. Good. So again, it breaks it down into acetyl-CoA and choline. Again, those can then be recycled and put back together, and then all of a sudden you have acetylcholine again. Again, that's important to know the enzyme that breaks that down because we're going to talk about ways we can reverse these and how what medications we can use to help get that effect back. Because again, if you have a patient who's over-paralyzed and you want to get them woken back up or get them to the skeletal muscle functioning again, sometimes you have to reverse that effect there. So we'll talk about that in a little bit. But again, a lot of this stuff gets recycled so it can be used again. So looking at Anectine or succinylcholine as our depolarizing neuromuscular blocker, and it's the only drug that fits into that category. Basically what this is going to do is that it is going to initially activate the muscle, and then it's going to wear it out essentially, okay? And so the benefits of succinylcholine, why it got used for a good long period of time now, and the use is starting to wane a little bit, but you're still going to see it used in most every ED out there, is we like it because it's rapid onset and a very short duration of action. And again, if a patient does not need to be paralyzed, you don't need to give them a paralytic, okay? So again, in that prescription assignment example, did you write for a paralytic? I hope you didn't, right? Because you didn't really need to, right? You guys remember that assignment? Perhaps. Anyway, but you wrote for sedative medications, but you did not write for any of these paralytics because again, if the patient does not need to be paralyzed, you don't need to do it. We're talking about for our side because again, initially we need to get all that muscle paralyzed so that way we can go ahead and put our laryngoscope in and get the patient intubated, and we don't want the muscles tensing up when we're doing that process. That's why we like the paralytics here. But anyway, so when I say a depolarizing neuromuscular blocker, also you're going to see the term fasciculation is being used here. What's a fasciculation? The twitching of the muscle, essentially. And so that's going to be seen with succinylcholine because initially it's going to activate the muscle. So you're going to see some twitching, and then eventually it's going to become paralyzed. Okay. So again, succinylcholine, actually what it looks like is 2 acetylcholine molecules put together. And so that's going to be important for how it actually works. So you're going to see that this is going to directly activate those nicotinic receptors initially, and then eventually you're going to see it's going to wear it out. And so again, metabolism is important here because it gets broken down by the same enzymes that break down acetylcholinesterase. However, some people actually have genetic predispositions to having less of this enzyme or more of this enzyme. So some people you give succinylcholine to and you say, okay, this should have a fairly short duration of action. Actually, it's a lot longer because they don't have the same amount of plasma esterase as, say, someone else might. So just know there could be some genetic variability there. But for the most part, it is a fairly short-acting neuromuscular blocker. So there's kind of 2 phases to the blocking that it does here with succinylcholine. And so the first thing that this is going to do is essentially bind to the nicotinic receptor. It's going to initially activate it. It's going to cause sodium channel opening. It's going to cause calcium release. It's going to cause the initial fasciculation. But then it just kind of sits there on the receptor, right? So it kind of sits there and kind of overactivates it at that point. So initially you see the stimulation, but eventually it's going to end up wearing out at some point, okay? And so as I mentioned here, on stimulation, acetylcholine causes kind of general flow of potassium out of the cell and sodium into the cell, right? Because remember that whole cycle, the action potential cycle we talked about there. But again, you're going to eventually find that by causing this, the cell's going to remain within the refractory period. If you remember, what is that refractory period? How do you define that? Can't really get back to baseline, right? So for instance, here if I were to draw it out, and it goes how much you like my drawings. So imagine here, normally if you have an action potential come along, you normally see the electric potential go up, and then it kind of goes back down, has a little dip, and then it gets back to baseline here. What maintains that baseline? The sodium-potassium pump, right? And again, what causes this initial rise in electric potential? Sodium influx when you're talking about the skeletal muscle, right? So essentially what you're going to find is that initially when you have the sodium influx, this is due to the acetylcholine binding to the nicotinic receptor and opening those up. Well, this remains bound here. You're going to find the sodium channels kind of stay open. Potassium is trying to come out in order to try to get back down to where it can kind of reset itself, but it can never get to that point. So basically you stay in that refractory period. So even if I have more acetylcholine coming around and trying to interact with that receptor, well, guess what? It's not going to do anything, right? You know, I can't have another action potential because it's still, that cell is still in the refractory period. So that's one way it's going to do it. The second phase is going to be basically this continued stimulation. You're going to find that the actual receptors themselves become desensitized, start to close off, so that way they're going to be less responsive to the acetylcholine that's actually there. And so again, by doing that, what you cause is going to be basically this flaccid paralysis. So initially you'll see fasciculations, you may see the patient twitching some, and then eventually you'll have enough of an overwhelming sort of desensitization that occurs where the patient is going to have a flaccid paralysis, right? So again, no muscular movement, no muscle tone in the skeletal muscle there, okay? This is the principal effect we're trying to get to, is that desensitization, so that way the patient is going to be able to remain paralyzed for as long as the drug is working, and then once it comes out, once it kind of gets metabolized, then you're going to find that resensitization process will occur, you get back out of that refractory period, and then the skeletal muscle function can happen again. Okay. And again, it's one of those things where because it's short acting and your intubation is not going as planned, you have to consider when to redose. So if this is only working, say 10-15 minutes, you've already had 3 attempts and the patient's not getting intubated, this is where you need to consider starting to redose, especially if you start to see the patient start to move around a little bit. So okay, let's give another dose, get them reparalyzed, that way we can get our intubation done really without any hindrances from the patient. Right? So again, looking at this, very fast acting, again, you want to give it about a minute after the sedative. Now why wouldn't I want to push these together? Well, you want to give your sedative time to work, right? You know, you want to give it time to get up to the CNS where it can actually knock the patient out. They're unconscious, and then you can give the paralytic in order to paralyze the patient, right? You never want them to be conscious during the paralyzation process. So we're going to do that. We'll get them paralyzed. And again, it's very frequently that, and I don't know if any of you have, I know some of you have experienced, you know, the emergent situations, but kind of what happens to the flow of time when you're like in a really like emergent sort of situation, like someone's coding? Everything seems to kind of either slow down or it gets really, really fast. It's hard to really tell what's going on, but people seem to think that like, man, it really feels like 5 minutes have gone by. You know how long has it probably been? 30 seconds. It gets a weird time dilation sort of effect here or there. Okay, we need to give more epinephrine. We need to give this. And it's like, it's been 20 seconds. Like, you literally just pushed it. You still have the syringe in your hand. Slow down. And again, you don't want to sound like condescending to the person, but oftentimes you have to kind of reset people's things and make sure you're using your stopwatch. It's like, no, it's only been so long. We have some time. Calm down, because people get very kind of anxious in those situations. Yeah, you definitely see those time dilation sort of effects there, where they're like, has it been 2 minutes? No, it's been 30 seconds. Just hold on. So anyway, make sure you give it about a minute or so. Let the sedative really kick in, and then give your paralytic. Now, again, in the case of RSI, if you guys talked about that at all in your CMS course at all, one of the other big things you're going to be doing along with giving the medications, what are you doing for the patient from a respiratory standpoint? You're going to be giving them oxygen, right? So again, you're going to be giving them, trying to flush out, get all that dead space of CO2 and all that out of the lungs, and so you're going to be giving them oxygen anyway. So it's not like the patient's going to be not oxygenating during that period of time. So you have some time to let the sedative work. Give it time to kick in, and then once the paralytic is on, you're going to find it onset within 30 to 90 seconds or so. Patient, you'll see those fasciculations typically, and again, it could be due to the etomidate you gave them, or it could be due to the succinylcholine. Doesn't really matter though. And then within 5 to 10 minutes, so the drug should start to wear off. Okay, because it'll get broken down by those plasma esterases, they get rid of it, and then the patient's muscle function should start to return. Okay. Now again, the patient may not be moving around if they have sedatives on board, but again, at least the function is there. It could happen if the patient started to wake up. Right. So, as I mentioned, it's going to bind to those nicotinic receptors. It'll desensitize them. It'll keep the cell in the refractory period, and that's what leads to initially fasciculations, but then finally to the flaccid paralytic sort of state there. Okay. So, what are some contraindications of using succinylcholine? This is the big reason why you're going to find that, especially most new providers, and in fact, a lot of kind of like a straw poll of like docs I'd be working with, and a lot of people who are coming out of residency or coming out of fellowship. Guess how many times they'd ever use this drug? 0. Almost never use it. However, we mention here because you're still going to find a lot of places where this is the go-to drug. A lot of providers still use this because this is what they're used to. Right? You're going to find this has relatively very, very short duration of action. So if you need to get back to where you can actually see if that patient's seizing, or if you need to be able to do a good neuro exam, you don't want a long paralytic, and so this is why a lot of people still like succinylcholine. But anyway, so there's some contraindications, and a lot of it has to go back to dealing with potassium. So if, again, as I mentioned here, when you bind to those nicotinic receptors, cause activation, you cause all that sodium influx to cause the initial fasciculations, but again, what other channels are opened up? What tries to repolarize the cell? What tries to cause the hyperpolarization? Potassium, right? So you're going to find the potassium channels open up. And again, potassium flows in which direction? In or out of the cell? It likes to flow out of the cell, right? Again, it's just all along the concentration gradient. So sodium's coming in, potassium's coming out. So what do you think it does to your potassium levels in the blood? Hyperkalemia can develop, okay? So is that a problem? Which organ is that particularly a problem for? The heart, right? So again, you can find life-threatening dysrhythmias can occur here due to the hyperkalemia you can develop secondary to succinylcholine administration. So this is the thing you gotta really be careful of. And so it's important to know who not to use succinylcholine in. Again, this is why history is so important in getting whatever you can get, either from bystanders, family members, the patient themselves if they happen to be with it beforehand, but try to get as much history if you can. So some of the things you want to be careful of. If a patient has had a severe burn that happened, say, 48 to 72 hours ago, what happens in these cases here, you're actually going to find that the cells will tend to upregulate these acetylcholine receptors, so that way when succinylcholine comes along, you have a much more exaggerated effect. You're going to see much more of the potassium start to leak out of the cell, and guess what? A lot more hyperkalemias are much more likely to occur here. You see the same thing with massive crush injuries that have occurred 48 to 72 hours ago, or a spinal cord injury. Again, notice here the time frame. Notice that if it just happened, the patient just had a massive crush injury, say they got into a car wreck, they're coming in and need to be intubated, they're okay to still get succinylcholine, right? It's only if you've given it a few days and they've had time to upregulate those receptors, that's when you run into problems. So that's one thing to note there. Neuromuscular glaucoma, this can increase your intraocular pressure. It's one thing to note there. And again, this is the other drug, along with your inhaled anesthetics, that can cause malignant hyperthermia. Okay. Remember, what causes malignant hyperthermia? You get too much calcium being released from the sarcoplasmic reticulum. Why is that? What receptor is altered? The ryanodine receptor, right? So ryanodine receptor is a genetic thing, right? It's a genetic predisposition. So that's why you want to ask if the family has any history of problems with getting general anesthetics or succinylcholine, or really any issues with surgery, meds, anything like that, because the patient might have it as well. Again, you might have a patient who's got no history of it and they're undiagnosed, and so you give it to them and they have the malignant hyperthermia anyway. If that occurs, how would you tell? How would you know if a patient is developing malignant hyperthermia? They get hyperthermia. hyperthermic. That's one way, right? What else? Get very tense muscles, right? Because again, they have all that calcium being released. The muscles are getting very tight. What else? Getting acidotic, right? So what are we going to give them to? What do you think happens to their entitled CO2 levels? In a very hypermetabolic states, they're going to be producing a lot of acids. They're going to be producing a lot of CO2 that's going to be breathed off. You can see that as well, right? It could be one of the first things you see with entitled capnography. We're monitoring these patients there. How would I treat that? Dantrolene is a good drug to use. What else? Got to cool them down, right? How am I going to do that? Cool IV fluids, good. What else? Ice, yep. Where are you going to put the ice? Armpits, the groin, neck, wrist, you have to, yeah. What else could I do? You do some evaporative cooling. Like if you get a big fan, you can put onto them and spritz them down, right? That can help out as well when they start to evaporate all that the water off. Those are all good ways to cool the patient down. And then what can I do for the acidosis? Sodium bicarb, yeah. So with dantrolene, sodium bicarb, and try to cool the patient down however you can. That's how you treat the malignant hyperthermia. Good to remember that because, again, if you go to a hospital, the two places where you're going to have a malignant hyperthermia cart, or the carts that have all those medications and drugs there, along with cool IV fluids, is going to be what two places? The ER and the OR, right? Because, again, that's the two places we've kind of talked about at this point. Because that's the two places that either giving succinylcholine or inhaled anesthetics, right? Anyway, patients who have a pseudocholinesterase deficiency, why do you think they may be a bad candidate for succinylcholine? They're deficient in the enzymes that metabolize succinylcholine. What can happen? The drugs has an increased effect, right? It's not getting metabolized right, so it's going to be sticking around for longer than what you would expect, right? So that would be another relative contraindication there. Any history like neuromuscular disease like Duchenne's muscular dystrophy, ALS, things like that, you would not want to use because, again, they also have that upregulation of those nicotinic receptors that could lead to hyperkalemia. And, again, they're a renal patient, right? If they're, they're dialysis dependent and they haven't maybe missed a session or two or something like that, right? And they get infected and they get sick, they need to be intubated. Check their potassium beforehand, right? What's the fastest way to check someone's potassium? Because you can, draw blood and stuff for BMP, but oftentimes if you get like an ABG or something like that, you usually have little machines at the bedside that can help you with that. They can actually help to determine what the potassium, right, is, along with the pH and et cetera. So hyperkalemia is going to be a contraindication because this is just going to worsen that, and then you have to worry about things like ventricular arrhythmias developing. Okay. So, as I mentioned, adverse effects of fasciculations can occur here, which we know it's expected. However, potentially that could lead to things like increased intracranial pressure. So, again, clinically, who knows if that's really all that important, but it's something that could occur. We know they get hyperkalemic. It's expected based off the mechanism we just mentioned here. Bradycardia can also occur. You see this especially a lot with very young patients, so again, little kids, and then, or especially infants, and then if you have to give repeated doses. So say, for instance, you don't get the intubation the first time, you need to give another dose, you're going to find that you can tend to get bradycardic when that happens. Okay. And again, what do I give to prevent that bradycardia? Atropine, right? So again, really little kids, you can give atropine beforehand, etc., right? Sorry, my phone was blowing up. I just want to make sure my wife was not like, the kids are dying or whatever. So I apologize. It was very, very unprofessional of me. But regardless. And again, just be aware, if they have that prolonged neuromuscular blockade, it could be due to the fact that you have that pseudocholinesterase deficiency, right? And then malignant hyperthermia, obviously, you're at risk for that, but you know how to treat that already. Okay, so again, as I mentioned, the fasciculation can worsen the ICP, can worsen the intraocular pressure, the IOP there, so something to know. Again, the ICP is really the clinically important thing to consider. Again, if you're worried about them having cerebral edema or any kind of increased intracranial pressure, again, maybe the drug to avoid here, right? And so what you're noticing here is that there's already a lot of things that you're like, well, there's so many contraindications here. Is there a safer drug that we can give? There is, right? We'll talk about that in a second here, but it's good to know these things because you're probably still going to run into this drug with some regularity if you work in an ER, right? Now, again, what can I do try to prevent some of this increase in intracranial pressure? Say you're out in the field and this is succinylcholine is the only thing you got to give. Well, what can I do to try to prevent those increases in ICP? Things you could do. One, trying to give lidocaine beforehand, right? Because lidocaine is going to do what? It's going to stop that gag reflex, right? So again, that's another thing that will cause an increase in intracranial pressure. That'd be one way. And sometimes you actually give a smaller dose of a defasciculating dose of a paralytic. This isn't done too frequently, but actually you'll give another paralytic beforehand. I say if you're doing that, why don't you just use that paralytic in the first place? So don't worry too much about that, but just know lidocaine can be given occasionally beforehand to try to blunt that increase in ICP. As I mentioned, normally you'd expect potassium to raise about 0.5 to 1 mil equivalent per liter for these patients. And again, what's a normal potassium? 3.5 to 5 is generally considered pretty normal. And so again, if you had a patient who's already at a potassium of 6, you saw it rise up to say something like 7, that could be pretty problematic again. Now again, is the total body potassium increase in these cases here? No, it's just you're shifting it out of the cell, right? Because all those potassium channels are open. So presumably, once the succinylcholine is out of the system, where does the potassium go? Back into the cell, right? The sodium potassium pump is going to kick it back into the cell. So this is a transient thing, right? However, that transient moment could be when they have the arrhythmia. So one thing you want to know. Other things that could cause rises in your potassium levels as well include things like rhabdomyolysis. Why would that cause hyperkalemia? Well, rhabdomyolysis is breakdown of all those muscle cells. What is contained in all those cells? A whole lot of potassium, right? So again, if you're breaking down all that skeletal muscle, it's going to break down, it's going to cause the potassium levels to rise. That's where you end up seeing that, right? And again, those receptor upregulations is typically in those cases where it's been a few days after, you can say 2 to 3 days after, you say crush injury, denervation, severe burns, anything like that, right? And again, these could be life-threatening, usually 4 to 5 days, especially post-injury. That's when it's going to be most critical. So we see that peak regulation of those receptors there. And again, if there's any risk for this developing, just skip succinylcholine. We're going to use a different drug instead, as we'll see in just a moment. Let's see. So yeah, as I mentioned, the upregulation of the receptors here, especially burns like 5 days post-burn, denervation, crush. We mentioned all these already, so just be aware of that. Now, again, if a patient has renal failure, it's not absolutely contraindicated to receive succinylcholine because, again, if I check a potassium and they're at 4, well, I can give them succinylcholine. It's probably not going to be a big issue. However, I have a patient who's coming in, I know that has a history of end-stage renal disease or on dialysis, and I don't have time to get a potassium beforehand. Would you use this? No, if I don't have the information, I'll probably just skip it and use something else instead, as we'll see in just a moment. Okay. And we talked about the malignant hyperthermia, very rare, but when it occurs, you need to act fast because, again, this can be potentially deadly, leading to rhabdomyolysis, disseminated intravascular coagulopathy. All these bad things can occur here. And so dantrolene, cooling, and bicarb are going to be our best friends, right? Okay, again, you can see that muscular rigidity. Actually, that's going to be a big thing. It could try to prevent you from getting your tracheal tube in place in the first place, right? That's something to consider there. And again, you find a lot of other issues: hypotension, hyperkalemia, myoglobinemia. What do you think all that myoglobin does in the kidneys? It can precipitate it out and cause renal failure, right? So all kinds of bad things that occur here. And so again, this is where you have to be really careful. Malignant hyperthermia, you know how to monitor for it. So again, checking the temperature of the patient, looking at the end-tidal CO2 to see if that starts to rise pretty precipitously. All these different things you want to be careful of, okay? Again, the temperature might not be kind of a late finding, might not be the first thing you see there, so that's why you want to monitor for these other things like acid-base status of the patient, looking at the end-tidal CO2, etc. Okay, now we talked about reversal agents, and why was it important to have a reversal agent for these paralytics? I would like the patient to breathe again. I need somebody to get these drugs reversed, right? So with succinylcholine, there's really no good reversal agent here. However, some people will consider using atropine if the patient's bradycardic, but from a respiratory standpoint, you just got to let the drug wear itself out, right? So you can give it 10-15 minutes, a little bit longer if they have a deficiency in the enzyme, and they should be back to normal, okay? This is less important to have a reversal agent for succinylcholine because it is so short-acting, because again, it's basically made out of acetylcholine, which is a short-acting drug anyway, or molecule. The other agents that we'll talk about, reversal agents for them, and that's going to become more clinically important, as we'll see. Okay, so some other special considerations. If they have a patient who's bradycardic beforehand, like an adult, I will go ahead and use atropine as pretreatment in those cases there, because again, I know succinylcholine is going to exacerbate that. That's one thing to know. And again, if I'm worried about ICP, that's where lidocaine is going to be useful there. Again, it's pre-medication. So think about these different situations, because they might be a good question on the test where I could ask a vignette saying, hey, this is the type of patient you have presenting, here's what you're worried about, what drugs are going to be best used for this patient, right? And again, the order of drugs is going to be important as well. So say I have a patient who is coming in with head injury, they smack their head on the steering wheel after a car wreck, and I'm worried about intracranial pressure. They're getting so, the pressure is getting so high they start to get bradycardic. I need to intubate this patient. What drugs would I use? In what order? So you would say, okay, well, for pretreatment, what would I use? Lidocaine, the ICP. What about for the bradycardia? Use the atropine, right? So of course those would be first because it's considered pre-treatment, right? And then what am I going to give next? Sedative, you use something like etomidate, and then you give your paralytic, right? So getting the order is really important as well because you don't want to give your paralytic beforehand or you don't want to give, say your pretreatment last, because that's not going to really do much good. Okay. And again, succinylcholine can be lethal in the wrong hands, especially the hyperkalemia risk. You have to be really careful. If you're not sure about what you're doing with succinylcholine, just use something else, right? And that's, again, why a lot of providers are very scared of using succinylcholine, because they have grown up in a world where they didn't have to use it. It wasn't their only option, and so that's why you end up seeing a lot of people kind of shying away from it. However, it's a very safe drug if used appropriately, and it's very effective at what it does. Okay. But just remember, it has no effect on consciousness, so you have to give a sedative beforehand. Okay, so up next we have our non-depolarizing neuromuscular blockers. These are much simpler in terms of mechanism. So whereas succinylcholine bound to the acetylcholine receptor, the nicotinic receptor, and cause activation and then desensitization, all that good stuff, this is just a simple antagonist, right? So these are just going to bind to those nicotinic receptors and just block the effects of the acetylcholine. Okay, so would you see fasciculations with these drugs based on that mechanism? No, because it doesn't cause any activation. It just sits there, blocks it, so it just leads directly to a flaccid paralysis, right? You're not going to see any fasciculations. Again, only going to be affecting skeletal muscles, has no effects on the GI tract, on the heart, no effects on really anything else, right? Not going to affect consciousness, etc. No analgesic properties, no amnesia. Got to give sedatives with these as well. So, vecuronium is a pretty common one used. This has a little bit longer half-life, as you'll see, than something like rocuronium. Rocuronium is probably the most common one you're going to run into from the emergency medicine, emergency department standpoint. VEC is also used occasionally, but this is oftentimes more used up in the ICU for more long-term paralysis, when you need to keep the patient basically more synchronous with the ventilator. If they're trying to kind of bucket a little bit, we can give them some paralytic to try to prevent that. This is nice because, again, as you'll see with the non-depolarizing neuromuscular blockers, there's no contraindications like what you see with succinylcholine. So someone can have a crush injury last week, they could have a burn, they could have hyperkalemia. Guess what? I can use all these drugs with impunity. No problems with that whatsoever. So again, a lot of people say, well, let's just skip succinylcholine, just go right to VEC or rocuronium. And again, you're not wrong, right? But of course, there's multiple ways to skin a cat. You never know that fateful day when you need to intubate that patient and the pharmacist calls up and you say, where's my rocuronium? I say, oh, actually, we're out. We have a shortage. You gotta use something else. You're like, what do we have? And I say, you gotta use succinylcholine. And they're like, So you gotta know what to do, right? So anyway, these are things to consider. Of course, always remember, how drugs come, especially if you're out there and you're the one managing medications potentially. Think about things like, okay, well, is my drug actually reconstituted? This one actually comes as a powder form, so you have to inject either sterile water or saline into it in order to get it into solution, then drop it and administer it, right? So little things you have to think about. And you know what that process of freeze drying is called? The drug? The lyophilization. So if I ever see like a lyophilized powder, that's basically where you just take all the moisture out of it. And what does that do? Why do we do that for drugs? Makes it last longer. It helps it with stability and whatnot. Usually anytime something is in solution, stability goes down pretty significantly. But anyway, again, this one has a pretty quick onset. You won't find it as quick, nearly as rapid as succinylcholine. The duration is going to be fairly short for the most part, but this one gets used a little bit more frequently as a continuous drip, especially up in the ICU, to keep patients paralyzed for a longer period of time. Now, note here that if patients have liver failure, they actually have 2 times the recovery time. So it's important to consider, okay, is the drug sticking around for longer, especially if you have them on long-term paralysis. You may take them off of the drip. You may say, okay, the patient should start to be able to move again. However, it may take some time for that to occur as the drug takes time to partition out, especially if they've been on it for a really long time, like say days to weeks. That's where you can really find a really prolonged duration of action. Not only is the tissue kind of built up levels of it, but if they're not able to metabolize it well, you're going to find the patient may be paralyzed for much longer than you would expect based off when you stop the medication there. Other things to consider, doesn't really cause any hypotension, no tachycardia, anything like that. So from a cardiovascular standpoint, it doesn't put any extra stress on that system there, right? It's okay if they're hypotensive, okay if they're tachycardic, this isn't going to worsen that, which is nice. Next, you have rocuronium. This is probably becoming or has become the more common paralytic you're going to see used in the emergency department. So if you ever have someone say, hey, where's my etomidate, my rock? That's what they're talking about is rocuronium when they say that, right? So again, it used to be etomidate and sucks being the most common. Nowadays, especially with newer practitioners, probably going to be etomidate and rock. Again, very similar properties to vecuronium. This one's nice because it doesn't need to be mixed beforehand, so it's probably another good reason why it helps with the rapidity of getting it ready to administer there. And also, there's less vagolytic properties than what you'll see with some of the other paralytics, where it doesn't cause necessarily tachycardia, any hypotension, or anything like that. So again, good from a cardiovascular standpoint. Again, working by competitive blockade of acetylcholine. Again, it's going to be important. We're talking about the reversal agent in a little bit, but basically just sitting on the receptor, the nicotinic receptor, preventing any activation will lead directly to that flaccid paralysis. So what effects do you think this has on, say, potassium? Should have no effects, right? Because again, it doesn't activate the actual skeletal muscle tissue. It doesn't have any activating properties. Does it cause malignant hyperthermia? No, it doesn't do that. It doesn't cause any bradycardia. Like, so again, all these things make it so it's much safer. Again, you don't have to think about it before you give rocuronium. You have to really think about it before you give succinylcholine. With this one, just easier. And so that's why a lot of people kind of gravitate towards this medication here. However, I talked to some providers, especially a little bit older providers, and they say, well, rocuronium has a longer duration of action. So if I needed to go and do my good neuro exam for my patient, then I want to make sure that I use something short acting. And succinylcholine is shorter acting than something like rocuronium. A lot of other people are like, well, the risk doesn't really outweigh the benefits, and so I want to stick with rocuronium. So you may find a little bit of a schism there between providers. Anyway, so how would you go about, so if you know the drug is sitting there on the nicotinic receptor, preventing acetylcholine from interacting with it, how could I reverse those effects? More acetylcholine, right? It's competitive blockade, right? So again, if I get more acetylcholine, if I bring more friends to the fight, you can just kind of kick that rocuronium right off the receptor there and have normal function again. And so you'll see this very frequently, especially in terms of surgery. So say, for instance, you have a patient under general anesthesia, you're giving them a paralytic to try to make sure everything is nice and relaxed. Then they're in the recovery phase, right? So you finish your surgery, you want to wake them up at that point. This is where a reversal agent can be very useful for that. And so we can use an acetylcholinesterase inhibitor to increase levels of acetylcholine, to kick that off the receptor, and then you should have normal function again, right? So it helps to increase the recovery speed for these patients. And so a very common one we have is called neostigmine, or Bloxifers is the brand name there, and this is a reversible acetylcholinesterase inhibitor that will increase levels of acetylcholine at the nicotinic receptor, kick the drug off, and then boom, your patient's moving again. Note here that this does not work for succinylcholine. In fact, what would it do to a patient who's receiving succinylcholine? Probably worsen it, if anything, worse than paralysis. Because again, how is the succinylcholine causing paralysis? Well, overstimulated and desensitized those acetylcholine receptors. So if I'm giving something that's increasing acetylcholine levels even further, it's even worse, right? So again, that would not be a good idea to give that. So if I asked a test question, I said, okay, you want to wake your patient up, they got succinylcholine, which these agents would work, you would say this is a trick question. There is no good reversal agent for succinylcholine besides the tincture of time, right? I would not ask a question like that on the test, but you can see where I'm going with that. However, what other side effects do you think you could see from an acetylcholinesterase inhibitor? Right, so the drug is not smart enough to just say, well, I only want to affect the acetylcholine that will interact with nicotinic receptors. It does it body-wide. And so, again, it's going to be affecting nicotinic and muscarinic receptors. So, from a muscarinic standpoint, an acetylcholinesterase inhibitor will increase levels. What effects might I expect to see? Dumbbells, right? What are my dumbbells? Diarrhea, urination. What's the M? Not do-bells. Meiosis. What are my killer bees? Remember? Bradycardia, rockorrhea, bronchospasm. Okay, what else? Emesis, lacrimation, salivation, right? And again, what do we say a lot of patients who are recovering from anesthesia do? Want to vomit, right? So again, this is one of those things where by giving them Zofran, you can try to head off some of this. But if I were to give them the neostigmine to try to help increase those levels of acetylcholine, try to wake them or get the muscles woken back up, you can end up finding that this could worsen things like emesis, right? Usually patients already have a catheter in from urinary catheter in, so you don't have to worry about that necessarily, but little things to consider there, right? You consider what the side effects of the reversal agents are going to be in relation to what you're already doing to the patient. So again, very fast acting, fairly short duration of action here. Again, 20 to 75 minutes. So again, if you wanted to really examine that patient, they're going to be paralyzed for a lot longer period of time than you see with succinylcholine, which could be, important depending on what the patient's presentation is, right? So just something to keep in mind there. And again, remember that you may need repeated doses. It's the same dose regardless. If you start to see the patient moving around or spend 15, 20 minutes, that's when you need to consider starting to redose the patient there. Now, as I mentioned, patients with seizure activity, you're going to find that neuromuscular blockers will block the motor responses to a seizure, but they don't actually stop the seizure itself. And that's where having if you have a patient you're considering who's seizing, you need to paralyze them. Make sure you're giving anticonvulsant along with it, so something like a benzodiazepine. And that's where you want to make sure you have a bedside EEG available. Again, it might be hard to get depending on where you're at, depending on what time of night it is, but that can be helpful to determine is the patient actually still seizing or not. Some other neuromuscular blockers you may run into. These are going to be used much more frequently in the, say, ICU sort of standpoint for more kind of long-term paralysis of patients who are on the ventilator. Now, again, do you ever see a paralyzed patient who's not on the ventilator? It's usually something that's gone way wrong in those cases there. Because, again, what did I say these paralytics are going to do to the diaphragm and the intercostals and all that? They're going to be done so, right? So, again, you got to breathe for that patient if you're going to be paralyzing them, okay? So, again, if you ever see one without the other, it's not going to. You can be intubated without a paralytic, but if you're going to have a paralytic, you need to be intubated, right? Anyway, so a couple other agents we have here include pancuronium and cisatracurium, or Pavulan and Nimbex. These are going to be also non-depolarizing neuromuscular blockers, so they work the same as VEC and rocuronium. No issues there. However, these tend to be a little bit longer acting. So again, these are better for more long-term sort of paralysis for these patients. That's why we end up seeing them more in the ICU setting than you ever would in the ED setting. Pancuronium is a vagolytic, which means what? The increase or decrease vagal tone. Decreases vagal tone, right? Because it's lytic, light, so it's going to be decreasing vagal tone. So you're going to end up seeing things like tachycardia. It may not be good for a patient who maybe had a heart attack recently, right? It may increase oxygen demand by the heart. So that'd be a patient you want to avoid using pancuronium in. Cisatracurium, on the other hand, though, is going to be a little more intermediate acting. The nice thing with this one, especially if you're dealing with ICU patients having multiple organ failure, you don't have to worry about this drug sticking around for longer than it should be because it doesn't really undergo any hepatic or renal metabolism / elimination. So it's good from those standpoints. So I see I've seen pancuronium used too frequently, but certainly in the ICU, I see a lot of Nimbex being used in order to help, especially with keeping synchronicity between the patient and the ventilator. Okay. Can you guys think of any other cases where I may want to have a patient being paralyzed for a long period of time? Sometimes I see it, especially after like neurosurgery, if I need to keep the patient from like moving, if they had maybe a partial craniotomy, where you don't want them necessarily moving around, things like that. Those are good cases where you need to paralyze the patient. Sometimes we'll do it if we need to put them in for a really prolonged, say, scan, like an MRI or something like that. So there's some cases there, but usually synchronization with the ventilator is the most common thing you're probably going to run into. I'll never forget, we had this one patient who was, when I was rotating in the PICU, we had this patient who had very severe intracranial pressure increases. They ended up having a craniotomy just to relieve that pressure. It was in the back of the head. And I remember that they were dealing with the monitor, and so I could see what the pressure was. And they're just like, you can't get the pressure down, And they realized that because they left the patient sitting like right there on the bed, so the pillow was basically pressing right on the brain there over the skin. And, oh, wait a second, we probably moved the patient a little bit, moved it, and all of a sudden the pressure went down. It's like, wow. Crazy how that works. Anywho, though, she was also paralyzed because you didn't want the patient moving around. So looking at this, we use long-term paralysis, again, to help things like synchronization here. Also, if you have a patient who is hypothermic, so say we induce hypothermia in a patient, when would we do that? If they've had witnessed cardiac arrest, in some cases we'll put the patient into a hypothermic state. We've seen some improvements in survival that way. Now, when your body gets hypothermic, what do you do in response to that? You shiver, right? Because your body's trying to get the temperature back up due to normal homeostasis. Well, we can actually give a paralytic to prevent that, right? So that can be useful trying to keep the temperature down for those patients there. Or, like I said, for facilitating diagnostic or therapeutic procedures, most commonly you're going to see things like MRIs or things like that that are kind of prolonged, where you want to keep the patient still. Now, what are some problems? If you keep the patient paralyzed for a long period of time, none of those muscles are moving or working. What are some risks that can happen there? Yeah, you can see atrophy of the muscles, absolutely. You see a lot of paralytic associated atrophy of the muscles. What else? Blood clots, absolutely, right. So if the blood is being very static there and is not moving around, then blood tends to pool, gets clots, and then you can develop, DVTs, PEs, etc. How do we manage that? How do we prevent that from occurring? You ever heard of SCDs? Those are sequential compression devices. Oftentimes, if you ever see like a little pump on the end of the bed in the ICU, those are usually have some clear tubes coming out of that. It's usually for sequential compression devices that will be wrapped around the patient's legs that will squeeze in a sequential manner in order to make sure to keep the blood on the venous side actually moving along, right? So that way it doesn't get very static and cause some clots there. Additionally, from my standpoint, what else could we do? Give them some Lovenox, give them some heparin, something like that. Again, we can give them a blood thinner, an anticoagulant, in order to prevent the unnecessary clotting from occurring there as well. So that's one thing you may see there in those ICU patients. Again, ventilator-associated pneumonias are very commonly seen, especially the patient's not moving around at all. Again, those bugs are just able to just kind of proliferate, cause pneumonia. Gastric ulcers you can also see as well. Again, gastric ulcers is another thing we're really concerned about in those patients anyway, because again, you're critically ill, you're producing a lot of cortisol. What does that do to your gastric protective barrier? Breaks it down, right? Because again, what does it prevent the production of? Prostaglandins, right? Just like if I were to give an NSAID, you can see a gastric ulcer develop from that. Same thing can happen for these patients, right? So what would I give to prevent that from occurring? PPI, H2 blockers are very common things to give. We give PPI like what? What could I give? Omeprazole. Usually give pantoprazole. It's kind of like the go-to IV agent. So Protonix is a pretty common one you're going to see there. Now, again, if I were to increase the pH of the stomach, what could that potentially mean from an infectious disease standpoint? Bacteria start to grow, right? Normally, the stomach should be pretty sterile, maybe a little bit of H. pylori growing there, but for the most part, it should be sterile because of all that stomach acid. Well, if they're in a stress state and they have all that cortisol and you're worried about stress ulcers, I give them a PPI to decrease acid production, and all of a sudden you're going to have the bacteria starting to grow, and then where'd the bacteria go? Yeah, so you can see these little microaspirations occur. Little bacteria just kind of crawl up the esophagus and then go right down the trachea, and then boom, you got a ventilator-associated pneummonia, right? Anytime you're introducing like foreign material into the patient, such as a plastic tube, bugs like to grow on that, right? And that's where you can see a lot of those pneumonias develop there. What do you think? Corneal abrasions, why do you think that would occur if the patient receiving paralytic? You're not blinking, right? You have no blink response there because those muscles are also paralyzed. And so frequently, if you ever see like artificial tears or some kind of ophthalmic lubricant, that is applied to the patients as well to make sure they don't get any corneal abrasions that develop. Again, is your patient going to be able to tell you, ow, my eyes hurt? No, because they're paralyzed, right? And then also these ICU neuropathies that can develop over a long period of time that can make it a very long road to recovery once they're actually able to be extubated and the paralytics are off. Oftentimes you can actually see things like aminoglycosides can also worsen this as well. And what's a common drug we use to treat ventilator-associated pneumonias? Aminoglycosides. So those are also going to be used, and that can worsen that neuropathy, right? So again, those are things we were concerned with, because if you think about ventilator-associated pneumonias, what kind of bugs are you worried about? Pseudomonas, Acinetobacter, all those really nasty gram-negatives, and that's why you need anti-pseudomonal drugs like aminoglycosides, like fluoroquinolones, and again, that can worsen that neuropathy that develops. So how did you actually monitor a patient to see how paralyzed they are? Well, we got this device called the Train of 4. This is one example of what one of these looks like. Another one looks like a little probe, like two metal balls on the end of it. And basically what you can do is test to see how paralyzed the patient is, right? Because again, oftentimes you don't want them to be completely paralyzed. You just need to be paralyzed enough to maybe be synchronous with the event, right? Or to sit still for a procedure. And so what you're going to find is that based off of this device, and basically is applying electrical stimulation to the ulnar nerve. And so when you apply it, basically you should be able to see the thumb move. Okay, so and it's called a train of 4 because it will send out 4 signals. And so depending on how many twitches you get, will determine how paralyzed you are. So if I'm very, very paralyzed, how many twitches should I get? 0. If I'm not paralyzed at all, you should see 4 twitches. So if I did it to you, presumably I should get 4 twitches out of you, right? Very kind of fun to play with if you ever get one of these on rotations or something. Anyway, not play, but experiment with, right? And you can see if they have 4 twitches, anywhere between 0 to 75% of the receptors are being blocked. And again, that's usually not sufficient enough for our purposes for paralyzing a patient, say for synchronicity with the event. But if they get down to say 2 to 3 twitches, 75 to 80% of those are going to be blocked at that point. That's enough to prevent those action potentials from occurring there. And notice you need to block a lot of those receptors before you actually have blockade of that transmission, right? Because again, it takes very little to actually get a good action potential developed there. Now, oftentimes you're going to see, especially with paralytic drips, they'll say titrate to 2 to 3 twitches on a train of 4, right? Those are going to be your monitoring parameters for those patients there, and it's important for the nurses to do that and monitor that, because otherwise if you go back and the patient has 0 twitches and your goal is 2 to 3, that's not really good, right? You need to decrease that paralytic dose you're administering to that patient there, right? 1 to 2 twitches is generally pretty considered to be pretty good for most situations there. Yep. Now, let's go back to intubation. Say you're trying to intubate your patient. You know, if you're, say you're doing a direct visualization, that doesn't work. Anyone know what else you can use to help intubate? Like this, it's kind of like considered like cheating a little bit. I see some people, people have this kind of gatekeeping personality where they're kind of like, oh, you can't even do it directly. You got to use the glide scope. You ever heard of glide scope? Basically, it has a camera on the end of the blade, and you can basically have direct visualization via a little monitor right there, and it's kind of like playing a video game a little bit. So you can try to snake your ET tube in. But anyway, so say it's not going well, right? So say you have a bunch of blood in the airway, or say something's happening, you can't get it. Think about redosing your medications. Think about how long these meds are working. If it's been 10, 15 minutes and you start to see the patient moving around, that's when you got to consider redosing. Again, if the patient's starting to wake up a little bit, do I want to just give them a redosing of the paralytic? No, if you're going to use the paralytic, you got to use a sedative with it. So I'll make sure you use both medications there. And again, situations are urgent, you may not be thinking straight in a lot of cases. You want to make sure you think about, okay, well, I'm going to make sure I give both these medications, give the sedative first, then the paralytic there, okay? Because again, patients are going to be harder to intubate when they're not paralyzed, and again, they need to be sedated for that. Okay, and again, just think about which drugs are going to be good for which situations, right? So think about, okay, well, if I have an asthmatic patient, ketamine is a good sedative. You know, if I have a patient with, you know, a recent MI, you know, some of my pancuronium is not a good drug for them. Think about these different situations in which one drug might be better than another. And remember, you got to have a good history in order to determine, okay, well, are they contraindicated from anything? Do they have a not flu vaccine, egg allergy? I don't know why I got stuck on that one. Do they have an egg allergy and I can't give them propofol? Do they have a history of dialysis, being dialysis dependent, and they can't receive succinylcholine because they're potassium 7? You know, all these things you want to consider there, and also just the patient presentation, right? So, any question on that? If not, let me check the board real quick. Discard those annotations. Let's see. All right. Let's see. If giving a benzo for induction, would you need to reduce the dose if you're giving an opioid for analgesia? Not typically. So, for instance, you know, the normal course of things, if you're using a benzo for intubation, you'd sedate them with the benzo, give them the paralytic, and then get them intubated, right? Once those drugs start to wear off, you'd start to consider giving the continuous infusion drips in order to keep them sedated. And then by that point, most of the benzos are worn off, and then you start them out on the Versed fentanyl drips, and then you kind of monitor them from there, right? And so typically you don't have to worry about reducing the opioid dose from that standpoint. Okay. If a patient has a prior crush injury or burn 3+ days ago and can only receive sucks, can you just give a lower dose? I've not run into that situation. It may even be to the point where you just might want to avoid using it altogether, like just see if you can use a sedative and knock them out enough to where they're not going to be fighting you too much to try to intubate them. But I cannot think of that situation where that has occurred. But there's not really good recommendations on that. I think most people would just say just don't use it at all because that risk for that hyperkalemia is so high that, you know, if they get into the arrhythmia, you're not going to really be able to treat it very well at that point. So, since rocuronium blocks both muscarinic and nicotinic when using a reversal agent, are the nicotinic effects prevalent as well? So keep in mind, rocuronium only blocks nicotinic receptors, right? So it's a nicotinic acetylcholine receptor blocker. That's how it works as a neuromuscular blocker. It works as a paralytic. The neostigmine that you're giving to reverse those effects will affect both acetylcholine that's able to affect, you know, muscarinic and nicotinic receptors there. But yeah, potentially, and actually we'll talk about this in the talk section coming up, is that if you have something that was blocking acetylcholine esterase, there are nicotinic effects you can see along with that. Have I mentioned the mnemonic we use for that? Yeah, it's the days of the week, right? So if you remember the nicotinic effect seen with, say, an acetylcholine esterase inhibitor, the M is, actually see mydriasis associated with that, right? What's T? Tachycardia, right? Because again, you end up seeing, again, normally you think about the muscarinic effects on bradycardia, but again, if you think about those ganglions, remember there's there's neurons going to be affected upstream of that, and so by interacting with that and affecting the nicotinic receptors, you can see tachycardia initially. Okay, what's W? Yeah, neuromuscular weakness, right? Just like we saw with succinylcholine, if I increase activity of acetylcholine at the nicotinic receptors, you see weakness develop and eventually can cause paralysis. Okay, how about HERS day? Hypertension, good, and then F? Fasciculations, and now you see why it causes fasciculations. Because again, initially it's activating those nicotinic receptors, causing the muscles to twitch, and then eventually they wear out, and that's what causes the weakness, right? Going back to the W. Okay, make sense? Okay. So I think that's it for questions here. Anything else I can answer for you guys before I let you go? If not, I will see you next time.